Hello, everyone. Hello to everyone joining us. We'll give a few seconds for people to trickle in. Hey, I see people are still trickling in. So hello, welcome to everyone joining us. My name is Debora Aguillon, and I am the manager, content and creative at Grand Challenges Canada. I have the pleasure of co-chairing today's session, Hearts and Minds: How Stories, Data, and Relationships Impact Decision Making in Mental Health Research and Implementation, along with my colleague Brittney Dudar, portfolio manager at Grand Challenges Canada. I would like to welcome all of you and those still trickling in. Thank you for joining us today. I do encourage you to introduce yourselves. We would love to hear where you're joining us from in the chat and what you're hoping to get out of today's discussion, which will explore what it takes to move from promising evidence to sustained implementation. Before I begin, I would also like to thank, on behalf of all of us, the International Alliance for Mental Health Research Funders and the Lancet Psychiatry Commission for making today's symposium possible. This is the final session in their symposium series inspired by the Lancet Psychiatry Commission on transforming mental health implementation research, and we're thankful for all your work to create these spaces where we can have these meaningful discussions. I also want to note that today's session will be recorded and shared, so you will be able to watch it again. There will be room throughout today's discussion for questions, so please do feel free to pop those in the chat. The Alliance team will be there monitoring and will be sharing useful links throughout today's session. Before I hand it over to my colleague Britt to introduce herself, our mental health work, and our first speaker, I would like to introduce Grand Challenges Canada for those of you who don't know us and share a little bit about what we do and our approach to storytelling as it relates to data. So, Grand Challenges Canada, GCC for short, is one of the world's largest impact first investors. Over the past 15 years, we have supported more than 1,500 innovations across more than 100 countries. With support from the Government of Canada and other partners, we invest in and help scale solutions that save and improve lives, promote equity, and strengthen systems in low and middle income countries and in Canada. At GCC, I have had the opportunity to lead the storytelling for our global mental health work, specifically for the Being Initiative, which Britt will introduce shortly, for the past 3 years. And I can say that our storytelling approach has always been to blend the personal element of stories with the impact numbers and the hard data to help us connect better with partners, funders, and most importantly, to elevate the voices, work, and impact of the local innovators that are addressing pressing health challenges in their community. We have also seen the impact of storytelling and data in the approaches of the innovators that we support, and we will dive into that more with a great case study from the Friendship Bench later in this session. The stories that GCC has produced that have been rooted in the lived experience of the innovators that we support have always been the ones that have resonated more with our funders and partners than the numbers alone. And that's because they provide a personal element that connect the why we're doing this to the what we're doing. And you'll see in the Lancet Psychiatry Commissions that this resonates, and they echo that storytelling should be a core part of the implementation pathway and that equity must be a part of all aspects of mental health research. So we must think about who sets the agenda and whose voices are being heard. Storytelling as evidence is another key theme you will hear throughout today's symposium, which also resonates deeply with GCC's storytelling approach. Sharing our lessons and stories as an innovation platform across the sectors we operate in have helped us drive engagements and create opportunities to inform programming and research, particularly in mental health. So, two examples I can share of this include the Mapping Youth Mental Health Landscape Report, which we published last year. This one captured insights from young people and mental health experts in 13 countries and highlighted what these stakeholders saw as the top youth mental health issues and key drivers in their country. This directly informed Being's investment priorities. And most recently from this year, our Youth Voices report co-authored with Being Youth Advisors, shared our reflections on what worked and what didn't in our efforts to meaningfully engage young people in grant making. It also included personal stories and calls to action from the advisors themselves to inspire other funders to more meaningfully include youth in decision making. So, all that to say, we believe in the powers of stories, especially in mental health research and implementation. They connect us with each other, they make us feel less alone and help combat stigma. They bring meaning, they build trust and help us learn from each other, and they inspire action. And when we combine them with evidence, as you will hear throughout today's symposium, they really do help create more opportunities for sustained system and implementation. Now I will pass it over to my colleague Britt to introduce herself, our mental health work, and our first speaker.
Great. Thanks so much, Deb. Good morning, good afternoon, good evening, everyone. My name is Brittney Dudar, and I'm one of the portfolio managers at Grand Challenges Canada. And I've had the opportunity to work closely on our mental health portfolio for the past 4 years and closely with our transition to scale mental health innovators that we have funded. So for the past 13 years now, GCC has invested over 65 million Canadian dollars in more than 100 different mental health innovations across 44 countries. I think making us one of the largest mental health innovation investors in the world. And these innovations seek to integrate mental health care into education, health, and social care settings. Over that time. And in the past 5 years or so, we've been focusing on addressing the mental health and well-being needs of young people aged 10 to 24. And in 2022, with our partners at Fondation Botner and the UK Health Department for Health and Social Care, the Sciences for Africa Foundation, the Government of Canada, Origin Global, and United for Global Mental Health, we launched the Being Mental Health Initiative, which invests in mental health research, youth-led innovation, and ecosystem building with a focus on prevention and promotion and the early drivers of young people's mental health and well-being in 12 priority countries. I won't name them all, but you can find them all online at on the Being Initiative website. GCC and Friendship Bench have a long-standing relationship. Since 2012, GCC has actually invested $3 million in Friendship Bench, including most recently in early 2024 when we partnered with the WHO Special Initiative for Mental Health on the Friends Project, which is a unique collaboration between WHO Zimbabwe, Friendship Bench, and the Ministry of Health in Zimbabwe, and we'll hear more about that partnership shortly and some of the exciting mechanics of systems change, as they put it in this summary for today's session, and kind of what some of that looks like in practice. But since the early days of evidence generation and validation to the journey now of integrating Friendship Bench into Zimbabwe's primary healthcare system, which is ongoing work, as we'll hear about today, we've seen how catalytic data and storytelling is and how critical it is to match evidence and data to the needs of decision makers. And we're going to get into some of the nuts and bolts of all of that today, and hear from some great live examples as well of things the team are navigating. So without further ado, I'm going to turn it over to our first speaker, Alison Schaefer. Dr. Alison Schaefer is a clinical psychologist from Melbourne with 25 years experience in humanitarian aid and development across Africa, Asia, and the Middle East. She's based in Geneva. She leads the implementation of the WHO Special Initiative for Mental Health on behalf of the Director for Mental Health, Brain Health, and Substance Use. I have the privilege of connecting with Alison fairly regularly on a couple of mental health projects that GCC funds, one of which the Friends Project, of course, we'll talk about today. And Alison is going to share with us a little bit more about the WHO's Special Initiative for Mental Health, including some lessons learned to date. So Alison, over to you to take us through your presentation.
Thank you so much, Brett. And good morning and good afternoon, good evening to some of you. And thank you for joining us today. As part of this introductory session, I was challenged with the task to talk about normalizing some of the challenges that many of us face in relation to adopting sustainable mental health reform. And it's a pleasure for me to share some of the insights today that we've been learning from WHO's Special Initiative for Mental Health and reflect on how we've been navigating some of the challenges of this adoption and sustainability of this reform across multiple countries and contexts. The Special Initiative for Mental Health was launched in 2019, and it set out to transform mental health systems and expand access to services for at least 100 million more people. Next slide. We're now 5 years in, and across 9 countries, I say 9, not 10, because Cambodia only joined this year, but across 9 countries, real change has actually taken root. So today, nearly 90 million more people have access to new mental health services in their communities, and at least 1.5 million children and adults have received care, most for the first time. And this scaling up effort hasn't been cheap, but we've managed to expand access to this almost 90 million people at just 40 cents per person. But I want to tell you, this progress didn't happen overnight, and it actually took us at least 2 years to get even startup numbers on the board. Next slide. Throughout the initiative, we've faced our share of barriers, and many challenges still persist. So the funding remains limited and unpredictable. Sometimes it's too short term or too specific, and it makes it tough to secure long-term support for systems level reform. Weak data systems has hampered some advocacy efforts, resource mobilisation, and being able to evidence our financial needs in mental health. Plus, weak data means tracking and reporting progress is usually project specific rather than systems wide. So we often get a micro view of data rather than a national view of data, and thus we fail to get a national view of the mental health needs. Stigma persists. We've found it to sometimes suppress demand for services and also to drive political will for change. And navigating political transitions, decentralised governance and fragile settings like in Ukraine, Bangladesh, and over recent months, Nepal, this all adds further complexity. But despite these challenges, we have been learning about some of the enablers which we think have been contributing to some of the transformational change that we've been seeing in our Special Initiative for Mental Health countries. Next slide. Speaking of enablers, I'd like to speak about six key areas. First, I want to say that time and continuity matter. Real systems reform takes years. Paraguay and Ukraine in the Special Initiative worked 3 to 6 years to change mental health laws. Ghana took 3 years to include just 4 mental health conditions in its national health insurance scheme. And in Zimbabwe, in this friendship bench collaboration that we have, even after multiple years of work, we're only now aiming towards sensitive discussions related to job descriptions and changes in the system for these task sharing approaches. In Jordan, mental health clinics grew by 27% through the Special Initiative, but that's been since 2022. So that's also taken time. The second enabler that I want to say is that our experience is that people matter. Local WHO focal points, national champions, and people with lived experience have all played a vital role in driving reforms forward in their countries. Their presence has ensured continuity, it's built trust, and kept the momentum for change very strong. Partnerships with academia and civil society, community leaders, they have all been indispensable. And I want to say that to invest in mental health is not just to invest in a solution or an innovation or necessarily just the people in need of services. It's also about investing in people who will manage and uphold the system in the future. The third point I'd like to make is that integration is, of course, key. We need to embed mental health into other program areas like maternal health, HIV, and schools, but especially into primary and secondary health care. And that's really helped us in the Special Initiative to expand reach. And this integration is starting to show signs of reducing stigma, increasing help seeking, and supporting some of the more sustained services. We've heard from GCC briefly about the importance of telling our stories, and we need to tell our stories in multiple ways for different audiences. We need to share our challenges and breakthroughs, help decision makers see what's possible, It helps communities and service users to feel seen and allows other countries to learn, adapt, and take their own actions. Lived experiences shapes change, and we continue to share stories, and their shared stories of lived experience will only continue to grow, I believe. Scientific write-ups help others learn about our experiences. It helps good practices to be replicated and negative experiences to be avoided. But this is conditional on the fact that we need to be publishing our challenges or failures, for want of a better word, because publishing this material is just as important as publishing our successes. And perhaps that's something that could be lacking in our literature across the board. The number 5 enabler is my personal favourite, and it kind of tells my life of running the Special Initiative for Mental Health over the past years. And it's that we need to embrace the fact that real implementation is messy. There is no simple 1, 2, 3 formula for large-scale change. Every country's journey looks completely different. No program, especially one at the scale and the scope of the Special Initiative, and one that aims for systems reform, will go from point A to B along a very smooth path. It's just unrealistic to expect that. There will always be unexpected needs, funding requirements, or situations that demand our attention along the way. We will never be able to fully retain the same health workers we trained. We need to keep training health workers. Implementation will inevitably take longer than we think, and real change at the system level will have its own sort of life journey in that country. The systems reform will never be 100% resolved or fixed or problem-free. I liken it a little to our personal life journeys, that systems change will always have room for improvement, revision, or necessitate a boost at times when things regress or look a bit troublesome. In the real world, implementation is complex and it's messy, and this isn't always conducive to research, which brings me to my 6th and final point. Implementation and research are different, but they can and should be complementary. The reality is that implementation and research have fundamentally different goals, and because of this, they don't produce the same outcomes or results. And the data that serves implementation, such as monitoring data, is inherently different to research-based data. Implementation data isn't always robust, and learnings can sometimes appear anecdotal or imperfect. We've had real challenges in our Special Initiative for Mental Health when it's come to monitoring data, and we've even had some people critique our monitoring methods and speak of our data as being weak, and I understand that. But that's because it's implementation data. It's not the same as academic-based research data. So for us to learn from implementation programs, such as the Special Initiative, we need to be embracing imperfect data and real-world results, even when it doesn't stand up to the rigors of research. But I want to be clear that I'm not saying one is more important than the other between implementation and research. We need both, and both need to continue being funded. They can't be funded necessarily in the same ways or given similar timetables, and we can't structure large-scale implementation funding the way we would structure research. Perhaps it's true to say that we need research to become messier and maybe implementation to be a bit more rigorous. I think something we could all be working on is trying to find some middle ground where the goals of implementation and research can be jointly achieved, with each of the work areas acknowledging the importance of the other. So I've got one last slide just to finish up, to say that the Special Initiative in recent years is teaching us that mass scale transformation and scale up is actually possible. And we feel positive that the progress we've made so far is likely to be built on further and be sustained, some areas perhaps more than others, in many years to come. But it's been inherently complicated and it's been challenging, and the changes that we've invested in the Special Initiative will continue to take their own future journey in each country. So I want to say to you that it's completely normal to have, and we should all expect, a bit of messiness and a few difficulties along this pathway. Just as people with lived experience help each other by sharing their journeys, we can normalise the ups and downs of reform and scale up by sharing our experiences and working towards improved mental health services. So I say, let's embrace the mess. Let's keep learning from each other. Let's listen and tell each other's stories and keep navigating our slightly chaotic and messy mental health world together. That's all from me. Thank you, Britt.
Thank you so much, Alison. That was great, and really, really appreciate your candor around some of the challenges of demonstrating implementation wins, I guess, and successes across such a systemic initiative like the special initiative. And so much of what you said really resonated with what we see at GCC in our mental health innovation portfolio as well. We're always talking about the nonlinear pathway to scale and sustainability, the pivots innovators make, the challenges and the barriers they encounter along the way, and the creativity it takes to keep going along that journey.
Yeah.
The cost effectiveness really stood out to me. I think 40 cents per person having access to mental health services is actually very, very low cost in my view. We see a lot of we fund a lot of innovators at the early starts of their journey when mental health innovations are quite costly and there's a lot of evaluation work involved, and it's not really like the long-term cost. So seems like good value for money to me with my investor hat on. But thank you so much. So I know we want to get into a little bit of a discussion today, and my first question I have for you is just reflecting on this tension between research, evaluation, and monitoring. Where does implementation science, I guess, fit? And in your experience, how do decision makers interpret different types of evidence?
Okay, what was the second part of that question?
Where does implementation fit?
Yeah.
How does implementation science fit within research, evaluation, and monitoring? And how do decision makers interpret different types of evidence?
Okay. So I want to say that when we set out to do the special initiative, one of the ideas behind it was that so many mental health projects are a mental health project over here and a mental health project over there, and this one goes for 1 year and this one goes for 2 years and this one goes for 3 years. And what we said was, what if we actually invested in one country for 5 years and provided some sustained support to those countries for a predictable period of time? What could we actually achieve at that systems level? And the consequence has been massive change in many countries, including changed laws, changed policies, changed referrals. In Paraguay, we've seen almost a complete deinstitutionalization to a decentralized approach. Now, what's interesting is we have never actually had research funding supported to the special initiative. And this is because I think research funding or researchers, I don't want to pick on anyone here, but they go in with a preconceived idea of what they want to research. And so when they come to the special initiative, there's not a lot that they really want to research because it doesn't match their preconceived ideas, because it's already on the way to implementation. The same could be said for implementation science. So we have actually approached some people and said, could this be an opportunity for implementation science analysis? And some of them have said, well, not really, because for implementation science to be effective, we need to set up a system, in a particular way to be able to determine what the rigorous differences are between, say, treatment as usual and an intervention, even at the systems level. So it's been really interesting to me that the special initiative hasn't attracted research funding. And I suspect that it is because researchers or research funders maybe are a bit concerned about not being able to get the data that they would like, or not, not being able to measure everything that they want in an existing program. So now, if I had my time again, we all learn, and I've learned 5 years on from leading this program. I would probably have carved out a little bit of a research element. So I feel that that's been a weakness, maybe, of the special initiative. But I suppose the concern that we had is we really wanted to focus on reaching the needs of people and providing that continuity of people to manage the program and doing the scale up. Like, we really wanted to focus much more on that implementation side rather than the research. And we were kind of saying, well, we're trying to actually implement the research knowledge that we already know. So I think perhaps we need maybe the researchers to come back and say, well, how can we research something that is current without our preconceived ideas? And for someone like me at the implementation level, I think I need to say, well, actually, we need to carve out a little bit of space here to allow for some of that research activity to go on. And I think the two is still actually possible. I actually think it could be interesting if someone was to provide some research framing for what we're doing, and we could still carve out the space for that. But at the moment, that hasn't quite happened. So I think that brings us to the need of working together. The other one, how do decision makers interpret the evidence? It's really interesting. We have all this research and we continuously find that we need to update our evidence to be brief, sharp, and to the point. So I was recently in Bangladesh, one of our special initiative countries. I was asked to provide a brief on the evidence in relation to essential medicines and the inclusion of new medicines, psychotropic medicines. And I was asked to summarize that in half a page. So, and you kind of like, and they said it has to be evidence-based. And you're like, oh my gosh, do you know how much evidence there is for this kind of thing? And I've got to condense it. So it's
What's
possibly
the critical message?
So it's hard for us to actually decide what to include.
I've definitely been the one asking for the consolidated briefs before, right? And so much of what you're saying resonates. I mean, I talk to researchers, implementers, and implementation science researchers all the time, and these are the very tensions in some of our conversations where we're saying, okay, do we need to do this much of a sort of RCT, esque embedded study within this project, or can we kind of focus on the next leg of the implementation science journey, and trying to find that balance and what's the right focus on research and funding as an investor is a very we have these conversations all the time. I do see one comment in the one question in the chat, Ali, from Vijay, and it says, is there a possibility of embedding research in implementation to break down silos and to be in touch with real world needs?
Yeah. Look, thank you for the question, Vijay, because that's where I was actually saying I started looking into some of the implementation science research methods, and I thought, we've got real world implementation, so can't we do some research on what this means and what the process has been? But in reality, I think implementation science is saying, well, we need comparators. So this demand for comparators is perhaps what has prevented, or what is perhaps a barrier to us doing more research in the real world implementation area. So and we would have to question if people studied it and looked at the data without those comparators, would that level of rigor be acceptable in the scientific community as evidence? So it does actually then bring us to the question of whether a research study on an implementation project or program is that sufficient to meet the rigor that scientists or evidence-based people desire. And I don't know that we've quite found that middle ground yet.
This is reminding me of some conversations I recently had with Dr. Teresa Betancourt and her team at Boston College. I'm sure she would love to chime in on this conversation, because this is actually exactly what we're trying to do more of in our mental health grants at GCC, you know, embedding research into implementation grants, and just kind of right sizing it, right? And making sure that it will be, you know, powered to detect differences, but you know, not solely funding that, because that's not what GCC does. As a, you know, we're not an exclusive research funder, so it's really about striking the right balance. So thanks so much for the question, Vijay. Okay, 2-minute time check. I think that was from 2 minutes ago for me. So I actually think, Ali, we might have to wrap up.
No problem. I'll be here the whole time.
Although there's one more question. Anna, do we have time for one more? I'm seeing, does this mean that we need to reconsider our research methods in mental health? Maybe we do not need research to build an evidence on the superiority of our interventions. We can learn from other disciplines. Absolutely, Prasansa, thank you for the comment. And I think we might get to that a little later on as well. But Ali, I'll just invite you to comment on that before we move on.
I think the comment stands for itself. So I do think that there is a lot we can learn from other disciplines, and I do think that we, you know, maybe RCTs are not always the gold standard. You know, RCTs don't tell us everything every time. There's a lot more knowledge to be had outside of the RCT space.
Yeah. Okay, great. So I know we'll talk a little bit later as well about different types of evidence, and we'll get into some more specifics. So thank you so much, Allison. This was really interesting. I know we'll see you later on, so don't go too far. Thanks for sharing your insights about the special initiative. That was fascinating. And I'm going to turn it now over to my colleague, Deb, to introduce the next session.
Thanks so much, Britt, and thanks so much, Allison. As a big fan of their storytelling approach, I'm really excited to introduce you to our next session, The Power of Storytelling, and our next speaker, Dr. Thandiwe Mashunye, a public health specialist and head of programs and government relations at Friendship Bench Zimbabwe. She brings over 12 years of experience strengthening health systems across Zimbabwe and South Africa, with a focus on equitable, community-based mental health care. In this session, she'll be talking to us about how stories and data have helped shape the Friendship Bench journey. Last year, I actually had the privilege to hear from one of Dr. Thandiwe's colleagues, Providence, their head of global and communications, about the Friendship Bench storytelling and advocacy approach. And I can say that they've truly been able to nail down what makes a good story, and most importantly, how to help decision makers understand their message and support it by using evidence to support their storytelling. And that's what Dr. Thandiwe will share with us today. Before I hand it over, I just quickly want to note that we will have time after the presentation for questions, so I do encourage all of you to pop some in the chat. Over to you, Dr. Thandiwe.
Thank you so much. First of all, I just want to thank the organizing team for giving us the platform as Friendship Bench to share a little bit of what we're doing, where we have come from, where we are, and where we are going. And specifically today, we'll be talking about storytelling, evidence, and the Friendship Bench, and how this has contributed to healing minds and shaping systems. So for us, storytelling has been like a core part of our growth trajectory since 2006. And why storytelling is very important to us. The first thing, storytelling, in mental health, most conditions are identified by, the diagnosis, treatment, the statistics. But for us, storytelling brings back the connection, the humanity. It puts a face to mental health. Our core values at Friendship Bench is that we believe in empathy, in connectedness, and we're anchored in research. So that connectedness, that connection between the people who are giving services to the people, the lived experiences, is very vital for our implementation. And you find that for us, storytelling is not just communication. We put a camera and someone just speaks, but we use it as a tool for for advocacy, for healing, and for systems change. And it has then acted as a bridge between the data that we have, right, and the emotion, the policies that are made, and the people who then have to live through these policies, and essentially the research and what is reality. So we have used storytelling to bridge those two things, the policy, people, research, reality, and data and emotion. And for us, storytelling is very important for from where we have come from and where we are going. Next slide. Next slide. Thank you. So you find that if you're looking at the friendship bench story, really, it's a collection of stories. And on the slide, there's a book that was written by our founder and global lead, Professor Dixon Chibanda, which really illustrates how friendship bench was formed in 2006. And the collection, and if you go through the book, it's not like we are describing any mental health conditions, but really it's a collection of stories that are a testament of our journey and how 14 grandmothers actually inspired a revolution, catalyzed a change across a nation in Zimbabwe, and actually now making impact even globally. So for 20 years, we have been telling stories, and this is the joy of one of my joys of being part of the friendship, is to tell the story. That's what I'm doing right now. I'm telling the story of friendship bench. I'm telling the story of our 14 grandmothers. I'm telling the story of our founder, Dixon Chibanda, and that's where friendship bench actually started. If you go through the book or our website, you find that it started through a story of grief and tragedy. Professor Chibanda lost one of his clients to suicide just because that person didn't have bus fare to go to the hospital to seek services from him. And he then found healing and solace in 14 grandmothers in Bare, a high-density suburb in Harare, where we started. And then that's where our own story started. So we leveraged on that story to say, hey, there's this untapped resource of grandmothers which are found within the community. They are respectable members within our community. They have lived experience that we can leverage on. As friendship bench, we just come in with a bit of training, problem-solving therapy, so that we can mental health services on the bench within safe spaces. So really, and you find that from 2006 to date, 3,000 grandmothers have been trained, and we are well on our way to see 1 million clients on the bench. And we are implementing Friendship Bench in all the 10 provinces in Zimbabwe, and the model has been replicated outside Zimbabwe in 10 countries. And this is through telling stories, and not just stories to everyone, but to funders, to people who then assist us to have this catalytic change. And if you look at it from our perspective, our storytelling is in 2 levels, really. First of all, there's the overarching friendship bench as the story, as a revolution, and this is what I've just explained. But there are also stories at an individual level, from the grandmothers to the clients, them sharing their lived experiences through loneliness, through depression, through resilience, through triumph, through grief, through support. So, and it's not just the grandmothers, but you also find even implementation teams within Friendship Bench who support the grandmothers. They have their own story to tell, how Friendship Bench has changed. Even myself, I have my own story of how Friendship Bench has changed my life, and how I now am able to inspire others to ignite change wherever they are. So you find that it's not just the grandmothers, but it's also the clients who are receiving treatment. It's also the people who are supporting the grandmothers. It's also policymakers. Later on, you will get to hear from Dr. Machando and Dr. Maunganidze, people who we have really worked hand in hand with, and their stories also matter in the growth trajectory of Friendship Bench. So individual stories are very important. They are personal, they are raw, and they bring that, like I said, the connection and the humanity in the mental health sphere that that what we work in. And a key question I think people might have is what really makes a good story? And I go back to our values as Friendship Bench. Our values as Friendship Bench is that we emphasize on empathy, connectedness, and research. So that authenticity, it's very important. The relatability is very important. Hope, stories that bring hope, that even in the darkest situation, there is always a light at the end of the tunnel. So those are the stories that we really prioritize. And you find that when all those little elements come together, then it then creates a good environment to advocate for change, either within the community itself, within a nation, at policy level, with funders. So all these elements matter when we're now advocating for the things that we need for within our programming. Yes, next slide. So this is the slide that I really like, and I like Alison really touched on this, that more often than not, we emphasize on the data, the RCTs, the hardcore data, the p-values, confidence interval, how wide or narrow is the confidence interval? Is your p-value very small? Is it significant? What is the cutoff point? Is it, So, but storytelling for us has provided another form of evidence that we can share with our partners, that we can share with our funders, that we can share with the world at large, to say, hey, this is putting the face to the data. And like what I say, the storytelling really extends as a bridge between the data that we're seeing, the studies that we're doing, and the emotion, the human aspect, and the people who are actually affected or impacted by what we're doing. So storytelling as another form of evidence is really provides a compelling package for us to say, hey, this is what we have been doing. Yes, we have shown efficacy, we have shown cost effectiveness, but behind those p-values, behind those confidence intervals, there are also faces of people. There are individual people who are living the experience of what we are investigating. And next slide, please. So if you if you combine the data and then the storytelling, it then leads to the advocacy, stories in action. So what we have really mastered is how to take these stories and then put them into action so that we bring about change on a systems level. We are providing healing, yes, through our grandmothers, through our delivery agents, but we are also using that platform also to then be advocates for change, whether it's at an individual level, whether it's at a community level or at a global level. We use those tools together with the hard evidence that that we have collected, and we have really, and these stories really have contributed to significant milestones within our own organization as Friendship Bench, and within the nation of Zimbabwe, mental health, and even at a global level, right? And on this slide, I just highlighted like one of the key projects that we're doing because of this advocacy, which is the Friends Project, a collaboration between WHO, Friendship Bench, and also the Ministry of Health, Zimbabwe, and getting funding also from GCC. So you find that through the storytelling, and like what Brittney highlighted, we have had a relationship with GCC for years, and we have used that platform and we have told the stories and also added the evidence. And now we are here. We started off with the RCT to prove the concept that the grandmother model actually works. Now we are at a stage where we are saying, hey, how can we scale this model? How can we have it integrated? And the Friends Project really has provided a platform, a unique platform for us to then collaborate with WHO, to collaborate with GCC, to collaborate with the Ministry of Health, and focus on key systemic issues like training, health system training, all those things. I will get to hear about the different things that we're doing later on. But this is one example, and there are many of them. For example, global summits that we have been part of, where we use stories to tell the impact of Friendship Bench within Zimbabwe. Yes, next slide. And just to round it up, so the key lessons that we have learned as Friendship Bench from storytelling: one, storytelling is evidence. It connects the data to the emotions. Community voices really matter. Grandmothers, whether it's the grandmothers, the youth, or the peers, these are very powerful agents of change. And when you give them the platform, right, they can actually verbalize what they are going through and connect with the different people that within our circles, to say, this is what is happening, this is what we need, and if we get this, this will then happen. And people's stories bring research to life. It's not just merely just graphs, and not that I have anything against RCT or hardcore evidence. So it's not just the p-values, it's not just the confidence intervals or the box whisker, but you actually put the people at the center of your research, of your story, and bring that impact to life. And strategic storytelling moves decision makers. And I gave the Friends Project as an example. So if you place your storytelling in strategic areas, you're able to drive change, which is equally important as proving that a model is effective, proving that a model is cost effective. So storytelling is equally powerful. And yes, we can advocate, but obviously there's that ongoing commitment and commitment and collaborations with policymakers that is then needed for us to then make sustainable change in terms of the interventions that we want to be doing, whether it's integration of a mental health model or it's scaling up of a model that you have, or for a youth model. Ongoing commitment is very key. Next slide. Yes. Also, yes, thank you. So I'll just end with just a reflection, just to say each and every one of us has a story, right? And we need to tell those stories at an individual level, at an organizational story level, and we have to use those stories to then connect with the people that we want us to help in terms of if it's implementation or if it's scaling up. So please tell your stories out there, because stories with a purpose really lead to transformation. Thank you so much. Over to you, Debora. Thank you.
Thank you so much, Tendiwe. That was a great presentation. I think what we've been hearing so far in this symposium is the power of combining the evidence with the storytelling and using that as evidence itself. So not to replace the RCTs and those values, but to really combine it and make that more powerful. And like you mentioned throughout your story, like at the end of the day, the funders, the other partners we're seeking to connect with, they also have mental health and they're also human. So these storytellings showcasing that human element are really powerful tools. And yeah, it's just amazing to hear how you've done it and have merged the two throughout the Friendship Bench and the Friends Project. We do have a couple of questions in the chat, and I do see people sharing some of their own stories in the chat. Although we don't have time for audio input in the call, I do encourage you to keep sharing. So the first question from Nirmala, who is from the Family Alliance on Mental Illness in India. I need clarification on who are the implementers. Are they mental health professionals or are they affected individuals and families? So in this case, I believe the implementer would be the Friendship Bench, but Thandiwe, please do clarify.
Thank you. So what we do as Friendship Bench is a mental health organization based in Zimbabwe, but we have replicated in 10 countries outside Zimbabwe. So we train non-specialist lay health workers to provide simple talk therapy on the bench, mainly focusing on psychoeducation, problem-solving therapy, behavior activation. Plus, we have a component also of a support group, Seko Kubatana Tose groups, which is an additive component, such that if a client has sat on a bench, they have an option to then join that support group as a way of continued healing. So the implementers, the organization is Friendship Bench. Who gives the services? It's usually the delivery agent. For us, it's the grandmothers within our communities. And then the model comprises of sessions on the bench and our support groups, the Seko Kubatana Tose.
Thanks so much. I do have a couple questions for you, Thandiwe. Speaking about equity, and this is a theme that comes up in the Lancet Psychiatry recommendations, and you've also brought it up in your presentation. How did you prepare community members to tell their stories, and how did you balance that emotional authenticity with what you needed from strategic messaging?
So for us, really, and I always repeat that we go back to our values, the empathy, the connectedness. So what we really emphasize, whether it's the grandmother who's telling their story, is the implementation manager, or is the client, it's authenticity, right? Tell your own story. And then us as facilitators, then we guide so that the story fits into the broader organizational goals or what's happening within the country. And the other key thing that we have also leveraged on is being culturally sensitive, right? When we interact with our delivery agents, when we interact with so that's very important to say, tell your own story within your own context, using the words that you understand, using the language that you understand, so that you don't take away the authenticity of what they, or tell their story in your own words, essentially, but you want them to remain true to what they're feeling, the emotion and their connection.
Absolutely. Yeah. Oftentimes their stories told in their own words are much more impactful than when we try to write it back. You mentioned like combining storytelling with the data, but also using it strategically. So back to that strategy, did certain policy or strategic moments make the stories that you were telling more powerful or timely for decision makers, sorry?
I think one event that really stands out is when we had the adoption of the model by the government of Zimbabwe. So we leverage on such occasions, either it's a summit or it's very important to bring the grandmothers in so that they tell the story and people hear from them. Even if it's funders, or it's always important to put them on the forefront to tell the story of Friendship Bench, instead of saying, Thandi, you're the head of programs. Can you tell us how the grandmothers do their work? So for us, it's leveraging on those particular, and particularly with the mental health, with the Friends Project, also at a policy level, we had the Mental Health Act review. So there were people with lived experiences there as well. So they also got to share their experience and get input into what is supposed to be happening within the review. So it's putting, I know most of the times it's people within the organization, you want to put yourselves at the forefront, but I think we now need to reverse that and actually put the people who are within the context. Yes, we have the evidence, but let them speak for themselves, let them tell the stories, and we support them and bring that structure so that they can able to articulate very well what they want to see and the change they want to see.
That's great. Thank you. One more question as well, because you mentioned, throughout this symposium so far, and you mentioned this a lot in your presentation, is combining the two, storytelling with the hard data. Can you give some examples, some practical examples of how you combine the stories with cost effectiveness and outcome data to make that compelling case?
So one of the investigations that we've been doing is for our CKT groups, our support groups. So we're looking at we're looking at economic indicators, whether there's improvement in terms of, because one of the things that they do within the support group are income generating projects, because given our context, money is an issue and it really leads to some of those common mental health disorders. So yes, we have the hard data that there's an improvement and economic benefit within these groups in terms of income generation. And also there's an improvement in terms of mental health outcomes. But what we also did is to collect the stories of the people within those support groups to say, for the years that you have been part of this support group, what has changed within your life, right? If it's getting money for me to pay school fees for my child, then it puts the face, rather than saying there was a 10% increase in income generation within this support group, but you're actually putting a face to that number to say, this is a client who was part of a support group and they actually experienced this and they are now able to grow vegetables. And they tell their own story, and most likely they don't even understand your numbers, or but they're actually saying, this is how I benefited from being part of this support group, and this is how my mental health has changed ever since I joined this group. So that's one quick example of how we try and combine, put the face to the numbers and data.
Thank you. As a comms professional, this makes me very happy. I completely agree that testimonials and hearing from the people themselves is the best way and the most powerful way to do it when combined with data. I do have one more question with you, for you. What would you say to others who are trying to do this and create this kind of change in their context?
I think we really need to define what evidence is, right? And we have been having this conversation, understand what storytelling is and how we can leverage on it to then produce results that we are seeking, and being able to connect with the different, whether it's policy makers, funders, or what you call this, or it's just the implementation teams that we work with. So understanding that bridge and how we can create a platform, people that we're working with, to share their stories. And the second thing is the values. I always go back to our values, the connection, right? Yes, we want money, we want funders, but really it's that human connection at the end of the day that we really inspire us to then say we want to share the faces behind the impact. And if that drives you, I'm sure, yeah, you'll put in the strategic moves to then combine the data that you have within your organization and bringing the emotion and the connection into what you're doing.
I love that. If that drives you, you'll put in the strategic element there. That's very powerful and super relevant to it, what we'll be discussing today. I also want you to know that people in the chat love what you shared about how you're putting people at the center of your storytelling. We do have one more question from the chat from Nirmala. How did you convince the policymakers that stories are evidence?
I think it's what I highlighted earlier, like you identify where the policy makers are, like for example, important meetings, important summits, right? Like I know we recently had the UNGA, right? Instead of your head of department going to UNGA, imagine a grandmother going to share her story at such a summit, and say this is what we're going through. And so that's how you can also convince policymakers to say, these are the people who are going through whatever they are going through, and these are the changes that they are asking for. So how can we then change policy? And yeah. So, but they also ask you the hard evidence, obviously, like they'll ask you, like, are you saying if grandmothers provide therapy on the bench, compared to someone who has gone to a clinic to see a nurse or a doctor, does that really work? They also still need the hardcore evidence. So it's a bit of both, but really strategically placing your champions, I like to call them champions, into key meetings, or even inviting them to be part of policy formulation, that is very important. And it also gives a platform for our policymakers to then get to interact with this with people who actually have gone through these experiences.
Thanks so much, Sandiwe. That was a great question and a great answer. And I think it really goes back to that theme that resonates throughout the Lancet Psychiatry Commissions about thinking like whose voices we're hearing, who is setting the agenda. And I think what you're saying and what Allison said and what we've heard so far in this symposium is that while storytelling is evidence, it doesn't replace the impact numbers. We still need those, but together they can be really powerful. So that are all the questions we have for now. So we will take a 10-minute break and we will come back at 10:11. Thank you, Thandiwe, and thank you all. See you soon.
Okay, welcome back, everyone. We're heading into our third session of this symposium, where we'll be talking about winning over decision makers. We'll be talking about the journey of Friendship Bench to health systems integration and some of the mechanics of systems change, including what evidence got the project this far, and what is needed for the next stage, and key implementation learnings to date. I'm not sure if you're all hearing my Teams notifications going off from another Teams call happening. So just give me a moment while I try and just disable those notifications. Just one sec. Okay, seems like you can't hear anything. So let's proceed. Apologies for that. Okay, so again, I'm Brittney, Portfolio Manager here at GCC, and I'm going to lead us into the next panel discussion with a great panel of speakers, all of whom are engaged on the Friends project that GCC funds, which is a unique partnership between the WHO Zimbabwe Country Office, the Friendship Bench, and the Ministry of Health and Child Care in Zimbabwe. So I'm delighted to introduce our speakers today, starting with Dr. Patience Mavunganidze. Dr. Patience is a psychiatrist and Deputy Director for Mental Health at Zimbabwe's Ministry of Health and Child Care. She's led tertiary mental hospitals, shaped national policy, and continues to advance evidence-based, community-focused mental health services, including work with the Friendship Bench, which she's actually been involved with for quite some time. Dr. Debora Machando is a mental health technical officer with WHO Zimbabwe, where she coordinates the Special Initiative for Mental Health. With over 17 years of experience in clinical practice, policy, and program leadership, she's helped to shape Zimbabwe's national mental health strategy and scale community-based interventions, such as the Mental Health Gap and Friendship Bench. And lastly, we're welcoming back Dr. Thandiwe Mashuniye. Dr. Thandi is a public health specialist and head of programs and government relations at Friendship Bench in Zimbabwe. And we just heard from her in the storytelling session with my colleague Deb, which was fantastic. Now, I'll just invite you all to turn your cameras on so we can see you, Dr. Thandi, Dr. Patience, and Dr. Debora. I see Debora, I see Thandi, and I'm just hoping Dr. Patience is with us as well. Dr. Patience, are you here? Let's give Dr. Patience a moment. Perhaps someone can send her a quick note that we are joining, that we are starting this this session. In the meantime, let's get started, because I know you can all speak to the different components of what we'll talk about today because of the highly collaborative way that you're all working together. And so my first question for you all is, what I know there's been a long-standing relationship here with the Ministry of Health being working alongside Friendship Bench, but we'd love to unpack a little bit what catalyzed the government coming on board and getting involved and really kind of taking up scaling Friendship Bench and integrating it into the primary healthcare system in Zimbabwe. What relationships or champions helped build trust in the model, and what was your personal role in this? And I was hoping to start with Dr. Patience here. If she's not here yet, we can certainly hear from Thandi or Debora first. Maybe Thandi, you can start. And Thandi, I just see you on mute here, but I hope you're with us. There you are.
Yes, I am. I'm just trying to get hold of Dr. Patience. She's having challenges with connecting her mic and her camera. So she'll be joining us just now.
Sure, no problem.
Sorry, what was your question again?
Yes. So let's hear from you. What catalyzed the government coming on board and taking up and integrating the friendship bench model? What relationships or champions helped build trust in the model, and what was your personal role in this? And we can start with you, Tandy, and then hear from Dr. Patience when she joins us.
Yes, thank you for that. I think for Friendship Bench, the key thing was relationships. So we have been working with the government for almost 20 years. When we started in 2006, that was one of our key implementing partners. And moving along, we have managed to strengthen those relationships and build, that's number one. And the second thing is evidence, providing evidence that the model that we have is effective, it works, and the stories as well tied to that evidence really supported the adoption process with MOHCC. And the third thing is having champions. So I know Patience will join us very soon, but Patience has been our champion for quite some time. She has been with the Friendship Bench before she joined the mental health part in MOHCC. So having someone as patient within the government, also we have leveraged on that relationship, on her championing Friendship Bench to then be integrated and adopted within the government. And one of our key relationships that we really value is WHO. So we have been working together for the longest time with Dr. Machando, starting with the analysis that they did under the WHO Special Initiative to collect data to present as a case for mental health within Zimbabwe. So you find that it's a collection of these different things that then created a perfect storm, a perfect platform for us to then say we're leveraging on these friends projects, on these relationships that we have built so far to then look at sustainability and integration of the Friendship Bench model.
Thank you so much, Tandy. And I'm just going to check with Dr. Patience. Dr. Patience, are you with us? I see you on the line, but I'm not sure if you're able to unmute yet. Okay, so let's carry on. I'm sure Dr. Patience will chime in when she is able to. I know she's been a long-standing champion of the Friendship Bench journey, having spent some time even in the early days herself with you all, I believe, as she was doing her training. So champions are key, relationships are key, evidence has been key. You know, I'd love to hear a little bit from Dr. Debora and from all of you, you know, what is a success or a win you've had so far in terms of integrating the Friendship Bench model into the Ministry of Health and primary healthcare system, and you know, something kind of very tangible, if you have an example that has been like a success so far in recent years in terms of handover and integration.
Okay, so maybe I can start by highlighting just a few things on the question that you asked earlier about what it is that catalyzed government coming on board. And I would like to emphasize the relationships, but in this case, it's also the relationships within the government system. The lay health workers are part of the healthcare system attached to primary care facilities, which makes them sustainable in that they are actually already part of the system. And then also the trusted intervention are based on the evidence, also based on a very trusted therapy, the CBT. So that intervention has been trusted, and it was then easier for uptake. And additionally, also that Friendship Bench has been working with mental health specialists in Zimbabwe, the likes of high level people like Dr. Mahunganidze, and also senior psychologists and senior psychiatrists. those are some of the things that made it to have a good buy-in, which leads us to one of the key successes around the French bench in Zimbabwe. There's been good buy-in amongst healthcare workers, and some of the evidence is that we see WHO coming in to support the Ministry of Health on that intervention through the Friends program. And we've had other partners also coming in, taking up the problem-solving therapy and integrating it in their work. So, for example, we've got HIV specializing organizations like OFID, like Zintex, ZHI. They have used the PST program for the French bench in building capacity for their healthcare workers. So I think it's an indication, it's an illustration of how that intervention has been successful in Zimbabwe. Thank you. Over.
Great. Thank you so much. Dr. Patience, are you with us yet? Just doing a quick check.
Yes. Sorry,
Oh, fantastic.
I was failing. I had to rejoin with another gadgets.
No worries. We all know how finicky these things can be. So thank you and welcome to Dr. Patience Mavunganidze. We're very happy to have you from the Ministry of Health and great to see you. I'm not sure if you caught the first question, Patience, but I know you've been a long-standing champion of Friendship Bench over the years and have been quite catalytic in your role at the Ministry of Health in, pushing along some of this integration into the primary healthcare system. So just going to invite you to comment before we move on what catalyzed the government coming on board. I know it's been a long relationship, but really kind of taking up scaling Friendship Bench and integrating Friendship Bench into the Ministry of Health. How did trust get built in the model, and maybe what was your personal role in this? And if you can, if it's not too much, to comment on something that's been a win so far or a success so far in terms of handover and integration and adoption into the government.
Okay, thank you so much. So as part of what the work I do, I work for the Ministry of Health, and I'm involved in different aspects of mental health in the country. And as ongoing work from 2021, we got funding and support through the WHO Special Initiative to do a mental health investment case. That was the first ever for Zimbabwe. So the results of that mental health investment case showed that we needed a low-cost primary care intervention to upscale, and so that we can increase access and then to improve outcomes, because the mental health investment case showed that if we do something now, if we invest in mental health now, we can then save more money later. So we looked at what was on the ground and what was there already, what the partners were doing and what we were doing as government. And then we realized, because Friendship Bench was already in the system and working, as you might know, they've been working in the primary healthcare section in Zimbabwe for more than 20 years. And for me, in terms of my role, I knew the Friendship Bench when I was training my undergraduate. I had an attachment at the bench, and they kept me in the loop throughout the years as I was still working at the tertiary care hospitals in Harare. And then when I then moved to work for the ministry at policy level, they kept me in the loop. They kept the office in the loop. So I happened to be in that office. And so when it was time for us to scale an intervention because of the mental health investment case that we did, it made sense to then say Friendship Bench has been around, and they've shown that through the research that they have done through all the years, and with my knowledge of the intervention, it is cost effective, and we already have the CADA. As you might know, the ratio that we had at that time, since we have improved since last year, since the previous 5 years. Now we are up to about 25 psychiatrists for the 60 million population. But then when we did the investment case, we were much less, we were around 16, which might not make a difference, but now we're actually saying we are better. So task shifting makes a lot of sense, and not just the psychiatrists, even the psychologists. The psychologists who are in government are limited in number for various reasons. So we needed a cadre who had the numbers, and the lay health workers who were being trained by Friendship Bench has the numbers, more than 2,000 in the country. And we had an intervention which had already been proved to work. So for us, we then said, why not? So we then had to present data to the other policy makers who are above me, which is from director, chief director, then the permanent secretary ongoing, to then say, this is the intervention that we have identified, which has worked so far, which has this data, and which we see when we think is cost effective. And then that's when we ended up saying, can we do a launch? Can we say, as Ministry of Health, we are taking this up as a national intervention? And so far, what has been a success? So this process has started, and we have come up with different we have identified the major issues we need to do. And some of them include the M&E, making sure that the monitoring evaluation framework is matching what we are doing as government and what the Friendship Bench is doing. And our M&E department is seized with this. And the other issue is what we need to do in terms of the curriculum of these lay health workers. So we have started the process. We are not yet there, but what we need to do now is to engage and adopt the Friendship Bench model into the day-to-day curriculum, or what the grandmothers are trained by us as Ministry of Health, so that there is sustainability. And after that, we will then need to train the tutors that train the grandmothers, and then we would need to come up with a monitoring or supervision framework, because before the Friendship Bench staff have been monitoring and supervising these grandmothers. So we would want our nurses, who are the next level from the lay health workers, to be able to supervise them and make sure that we have the same outcome, or we then maintain fidelity in terms of, when it's from research to implementation at large scale, we might lose that. So that's what we have started doing. Thank you.
Great. Thank you so much, Patience. You covered so much. I just want to highlight or underscore a couple of key things you mentioned, which builds off what Tandy was saying. The criticality of evidence. Evidence has been key to catalyzing government adoption, but specifically the investment case for mental health in Zimbabwe for the prevention and management of mental health conditions. And thank you, Allison, for flagging that. I think that's a great win of the special initiatives of what as well, kind of having funded some of that work, which seems like it was a key piece of evidence for Patience and her team to have in hand to advocate. And then also within that, having a locally based, locally led, locally evidenced intervention seems like it was a key to kind of taking it to the why not phase and the let's get started with this. So thanks, Patience, for that. You started to get ahead of me and answer Vijay's question from the chat on challenges and barriers to integrating mental health into primary health care, and you talked about the M&E needing to match between Friendship Bench and the Ministry of Health, and the curriculum and whatnot, some of these components that you're working on. So let's shift to the next question here, and just talk a little bit about what does the handover look like, and what does a sustainable transition look like? What challenges do you either anticipate or are you currently navigating? I know you're currently working on all of this together. So what's a current challenge maybe that one of you would like to share, that you're currently trying to tackle together? Whoever would like to start.
I think some of the challenges, Alison highlighted them in the in her initial slide, that the winds are slow, right? And you have to be patient really to put the correct aspects into place. So we are quickly realizing that this is going to be a long-term process. It's not an overnight process, and it needs a lot of lobbying and also resources, financial resources and funding. So I think from my end, I think that will be a key challenge with what we're doing. Yes, we're looking at sustainability at the end, but the initial phase when we're putting up the structures, the training, the capacity building, the policy changes, you really need to invest in that. And then after that phase, you then look at, right, how can we now sustainably implement the model together? Yes.
Okay. So the challenge that I'm seeing, besides what Tande has already mentioned, is the fact that the Friendship Bench was doing this work, supervising, training, and supporting the process financially. We are anticipating challenges in buy-in, and buy-in from which cadres. So the nurses, we are expecting the nurses to supervise, and we are adding on work on already people who feel that they are overburdened with work. And we also need the buy-in from the tutors. So they have been training these grandmothers for years with the usual curriculum that they train. So if we add on, currently the Friendship Bench would take 10 days to train a grandmother. So if you are going to tell them we are going to train 10 days more on what you're already doing, I think we would need to work on their buy-in. Then we also have challenges that I think every third world country is facing, staff turnover. So if you train this nurse, now you're now competent to supervise, maybe after a few months, they are not there anymore. They might move in country or move outside the country. The staff movements out to outside the country has slowed down, but it's still there. Then we also need to make sure that these people that we are training will have protected time. Because of the numbers in our clinics, we tend to have our mental health trained nurses being put in other departments. Therefore, they end up not having enough time to focus on our clients. So we will need to work on that as well to make sure that these cadres that we are training, they have protected time, and hopefully they'll be able to stay long enough to then do the work that we are training them to do. I will end here and allow Dr. Machando to also add on. Thank you.
Thank you very much. Yes, I think the big issue that we are faced with is the one for sustainability, specifically financial and resources constraints, because the national mental health budget, while there is lobbying for it to be increased, it still remains limited. competing with other health priorities, such as other conditions like HIV, TB, and maternal health, for example. So being able to sustain the service providers, the lay health workers, the way they're being supported through Friendship Bench, it's still a challenge that everyone is grappling with, trying to figure out how it's going to look like in the future. And then, as Dr. Maunganze says, we are constrained in terms of the healthcare workers who are supposed to support the lay health workers because of high staff turnovers, for example, amongst other things, in the competing workloads that are there. So those are some of the challenges. Also, Friendship Bench is very specialized data systems, and I'm happy to say that we are currently trying to integrate that into the DHIS. Some of the challenges that we might face include even lack of internet connectivity at some of our health facilities, and then also the coordination that is required for that to be as efficient as possible. We are also glad that we've started the issue of reviewing the Mental Health Act, but as Alison pointed out earlier, it takes years for that to become operational. So, and we are still at the very beginning of that process, but we realize that we need policy level, we need policy level strategies to be able to ensure that integrating lay healthcare workers into the system is effective. At least it has to be enforced by some kind of legislation.
Yep.
So those are some of the challenges. And
Thank you. Thank you, Debora. You're all painting a picture of how messy implementation can be, as Alison put it earlier, and that's what's so interesting, I think, and fascinating about it, and also so complex, right? So there's a question in the chat that's getting a lot of love I'd like to pose to you guys. It's great to hear about the Friendship Bench and its effectiveness in addressing depression, given that Friendship Bench and many other global mental health projects often rely on women as non-specialist providers who are frequently unpaid or underpaid. How can we address the equity concerns that arise from this model? I would invite Dr. Patience perhaps to comment on this, or Dr. Tandy, let us know how these considerations are taken into the mix.
Sorry, I didn't quite get the question.
Given that Friendship Bench and many other, task shifting approaches in mental health often rely on women as non-specialist providers who tend to be grandmothers or community healthcare workers and are underpaid or unpaid, how can we address equity concerns in this approach?
Okay, yeah, it's actually a big issue. But for us, the good thing is these lay health workers are already employed by the government, so they are being paid for the usual work that they do, even though it's not as much as we would want them to get. But they are being paid as other healthcare workers. So that is an advantage. How we can improve that is, I think, is the $1 million question for all of us. And my colleagues can also add on.
Tandy, did you want to add to that?
Yeah, I think patients really, that's the answer that I had is as Friendship Bench, when we're now looking at sustainability and how we can integrate the model within the government, realizing ultimately if we are going to have more numbers, it's these partnerships, be having the government be the doer and pay at scale. So leveraging on the aspect that some of the community health workers are already being paid under government, it's looking at what probably not all of the work that we have been doing under Friendship Bench, but what certain aspects of the model can be integrated in the day-to-day activities that they do, so that at least there's that balance as well to say they are also involved in other disease-specific activities, and now there's mental health as well. So there's that need to have that balance as well. And just to say that as Friendship Bench will still be offering technical support as well, and also lobbying to funders to support the government, also to then be able to support the community health workers. So that's something that we're also looking at in terms of how can we also support the government as a technical partner and not actually doing the implementation process as we are looking to sustainability. But like Patience said, it's $1 million question. And what we're leveraging on as Friendship Bench is the aspect that these community health workers are now under the budget, the national finance budget. It's not much, but it's somewhere where we can start from.
Great. Thank you so much, Shandy. I hope that was helpful, Prasansa. Thanks for the question. I want to jump to another question I want to make sure we get to today because of the unique partnership and the way you're all working together. And I know we've talked a little bit about this together in our previous calls, but would love to hear a little bit more about how this partnership between the Ministry of Health, WHO, and Friendship Bench is going. I think we, if you want to share a little bit about how it started, that would be great. But very much curious to hear about the benefits of working together in partnership with the country office and with the Ministry of Health and with Friendship Bench. What's surprised you about its benefits, or what's going really well about this way that you're all coordinating and working together?
Okay, I'll start and then the other guys can come in. For me, what surprised me the most, or what I value the most, is the fact that we have a mental health focal person from WHO who's coming in between us and Friendship Bench and bringing us together. Why I say that is because as Minister of Health, the mental health department, we assist with many other issues, including the issue of drug and substance abuse that has been, we have been seized with that since COVID. So so among other issues, we then tend to then felt to then completely focus on the Friends project. But with having WHO with Dr. Machando along, she had just been keeping us on track and making sure that the work doesn't stop and it's not derailed by our other commitments. So that has been key for me in all this work that we have been doing. Thank you.
Excellent. Great to hear. Dr. Debora, did you want to add on that?
Yes, thank you. I wanted to say, as WHO, we bring in the technical expertise across the different levels, but we need structures to be able to operate in. So MOH structures have been useful. And then we've got the Friendship Bench model, which is very well established. And they already have relationships with the different government personnel as well as the community. So we found that operating together is very useful. We leverage on each other's strengths, and that has been super, super useful. Thank you.
Excellent. Tandy, did you want to say anything?
Yes, I think from my end, it's leveraging on the combined resources and skills. I think that has been very crucial in the different activities that we have done together. And also, I think we have been realizing that as Friendship Bench alone, integrating the model won't work. So it's essential to look for key people and key resources. So collaboration and leveraging on the resources, combined resources and skills and expertise has really helped us.
I hear you loud and clear that having a dedicated focal point within the WHO special initiative has really helped kind of move things along, given the multi focus areas of the Ministry of Health and all the different directions you and your team must get pulled in on any given day, patients. So thanks so much for highlighting that. And I think when we spoke in a previous prep call, it might have been patients, mentioned just the focus and the coordination of all working together in this way, rather than everyone kind of focusing on their individual component of their goals in mental health. The kind of focus. I wonder if you could just briefly comment on that, because I thought that was really interesting.
Yeah. Okay. So the fact that we have a focal point who's dedicated to the special initiative, like that's her day-to-day work, it then makes sure that we have someone who's focused on the Friends project as well, and therefore we don't lose that focus of saying this month we have to do the following. So irregardless of us being pulled to other directions or other commitments, the work still continues, which is great, because I'm seeing in a scenario where if it was just the Minister of Health and the Friendship Bench only, we could have us failing behind because of complete competing priorities. So because we are coming together as three entities and one of us is completely dedicated with the work or for the work and is focused on that, that has been key for our implementation.
Great, thank you so much. There's a question in the chat around discussing the process of onboarding grandmothers as paid government employees. Okay, we kind of covered that. I'm just looking at Jeffrey's comment here, but he does ask, how about having Friendship Bench continue to supervise? Is that possible or problematic administratively? I think the goal here is for you all to shift that that oversight and quality and monitoring responsibility to the ministry, right? But I'll invite you to comment on why that's the case.
Thank you. So I think for us, the simple thing is scaling the model and sustainability. So if we're going to see more people, reach more people, close the treatment gap, we really need to then look at the different partners and resources that we have at hand. So as Friendship Bench, having the capacity to then be able to train all the community, there are up to like 20,000 community health workers in Zimbabwe, and having the capacity and funds to train all of those people and pay them, I think it will be beyond but we still have a mission and vision, getting people out of depression, having a Friendship Bench within walking distance for all. So to fulfill that is then partnering with government, so that at least we can see how that integration process can then still lead to seeing more people and having a sustainable approach.
Thank you, Tandy. Did anybody else want to comment on that, Patience, Deborah, before we move on?
I think Tandy has said it clearly.
Okay, great. I'm going to shift gears here to ask. We've touched on this a little bit around some of the challenges you're facing with integration, but what structural or policy shifts are still needed to make this stick? For example, job descriptions, curriculum integration. You've touched on a couple of these things, the Mental Health Act. Can you kind of highlight one or two of the key structural or policy shifts that are still needed to make this integration sustainable? And if I may add to that, what kind of evidence do you need on this next leg of the journey? Do you have all the evidence you need at this point, or do you need more? And maybe I'll start with Dr. Patience.
Okay. So in terms of the structural changes we need, so if we are going to add on includes the French-Benny model in the curriculum, it then means at policy level we have already approved that, and that's now part of ongoing work. It's no longer coming from Friendship Bench, it's coming from us. And also the fact that I mentioned that the nurses are going to be supervising, then that's also a structural change, because Friendship Bench was supervising before. And in terms of the allowances that Friendship Bench has been giving the grandmothers, it means that has to come from government. That's also a structural, a policy shift that is going to happen, especially in the fact that it was add on to whatever little that they were getting. So that's going to need a shift. Then do we need more evidence? So far, I think what we have is more than enough. And I think what we are going to see is the learnings we are going to get from all the processes we are going to do. Obviously, we are going to meet different obstacles and challenges, and those learnings will be then something we can then say, whilst we were doing these changes, this is what we encountered, and this is the challenges we faced, including the buy-in that I mentioned before. How we are going to navigate that is going to be something that we are going to learn from, and to also having to share with others who are going to do the same processes. I will end here. Thank you.
Thank you so much, Dr. Patience. Tandy, Deborah, anything you'd like to add to that? And I'm also kind of curious, how are you all learning together about the implementation science of it all, the implementation, the processes? You know, do you reflect on this regularly together? Are there a few key, papers or learning agendas that kind of guide this element of the work? I'm going a bit off script here, but I'm curious how you do that.
I will go first. Some of the things that we are learning is that we need to have human resources, the human resources structure strengthened more. For example, we have provincial level mental health officers who at least have that office and they focus on mental health leadership alone. But from the provincial level, going down to the districts and into primary care facilities, we do not have a dedicated role for mental health leaders who would be the supervisors for this program. The current structure where you have district mental health officers is not a substantive structure. So we look forward to the government formalizing these positions, coming up with a structure across all the levels of the healthcare system, so that such roles as supervision can be tackled. And then also embedding this into the curriculum ceases to have people thinking about it as a program or a project, but they begin to know that it's something that's done at scale. I think those are some of the major changes that can be done.
Thank you. And just to touch on the research and what we do, so together, Friendship Bench, WHO, MOHCC, we have regular quarterly stakeholder meetings where we review our data, the different indicators that we have for the project to see where we are we achieving those, and are there any challenges, and specifically map out the different activities that we are going to engage either in the following quarter or half year. So that has been really helpful for us to touch base and really think about sustainability, think about implementation and what resources are needed. And also in terms of collecting data, we have a research component also embedded within the project that has been approved by the research units here in Zimbabwe. So it includes the WHO survey and some work on social connectedness that we're doing within as Friendship Bench. But one thing I think from our end as Friendship Bench that we want to focus on next year is the health system strengthening indicators, because we have seen that those are really quite critical in terms of sustainability and supporting integration pieces. So actually looking at what exactly can the government absorb if it's going to be sustainable, and what role will Friendship Bench continue playing in terms of integration of the model within the system. So we're trying to understand that delicate balance to say, as a technical partner, where do we end and what do we still need to continue to support the government with so that they can continue Friendship Bench work, and what are the kind of resources that government has also to then sustain the model in the coming years. So those are some of the things that we're planning to look at in terms of implementation research for next year. Yeah.
Excellent. Thank you so much. I think we've heard so many different challenges, barriers, opportunities, things you're navigating together. I'd love to just wrap up by a question I'm not totally sure we got to earlier because we've covered so much, but maybe you could all just briefly share with me the one win or success that you're most proud of so far in the work that you've all been doing together, and then we'll wrap this panel up and move on to the next part of our reflection together today. And I'll ask Dr. Debora, perhaps you can start.
Thank you. I think what has been incredible for me is how we have been able to increase access for mental health services at very low cost using evidence-based interventions. Because evidence is very important to WHO. So I found that this has been a huge success. Thank you.
Thank you, Dr. Debora. Okay, Dr. Patience, what's been the big win so far for you, or the thing that you're most excited or proud of?
Okay, I think the one I am excited or proud of is the fact that through sustained and kept on for a long time relationships, I feel the relationship I've had with Friendship Bench for over a long time, the relationship I've had with Dr. Machando and Tandy has been key. And I've known Dr. Dixon Chibanda for a while now, since I was training and he was also training. So those relationships over the years and the relationships that Friendship Bench has had from the primary care, the districts, and with the provincial mental health officers and mental health directors has made a difference. And I would say that's my major takeaway, that relationships do matter, and we ought to put value if we are going to transform research into implementation and to increase whatever intervention we have to scale. We need to value the relationships that are there, and to maintain them from the start of the project to the time where we need to then implement or cascade it to the next level. Thank you.
Great. Thank you so much, Dr. Patience. That's nice to hear, and certainly a key thread throughout this whole conversation today. Tandy, you can wrap us up. What's the big win or success from this partnership so far from your side? Something tangible that you're most proud of. Oh, I'm not sure if we lost Dr. Tandy.
Looks like
she may have fallen off. Okay, that's no problem. We'll shift to our next session here. We are going to invite, so thank you so much, Dr. Debora and Dr. Patience, for sharing all your insights. That was a really rich and interesting discussion. Every time I talk with you, I learn so much about the mechanics of it all, and it's really fascinating stuff. So I look forward to learning more because I know this work is still ongoing, and we've got another year or so of funding it together, and lots more likely to come. So don't go far, because I know we're going to have an opportunity to hear from you all shortly as well as we wrap up this session shortly. But we're going to switch gears now to invite the chairs of the Lancet Psychiatry Commission on Transforming Mental Health Implementation Research, Beth McGinty and Matthew Eisenberg, who are going to reflect a little bit with us on the conversation they've heard today, which is the third in a series that the IAM-HRF, the Alliance, has been hosting this year. Dr. Matthew Eisenberg is a health economist and associate professor at Johns Hopkins Bloomberg School of Public Health. He focuses his research on the impact of healthcare policy on mental health and substance use. And Dr. Beth McGinty is chief of the Division of Health Policy and Economics at Weill Cornell Medical College. Her research explores how policies shape outcomes for people with complex health and social needs, bridging economics, policy, and implementation science. Welcome, Beth and Matt. Great to have you both. And if you could turn on your cameras, that would be great, so we can see you, and hopefully you are here and with us. There you are. Awesome. I see you. So thanks so much for joining us. You have both had the privilege and the benefit of being along this journey for the whole symposium series this year, I believe, and having heard the previous conversations that Deb and I did not necessarily have the benefit of hearing, but we would love to get some of your reflections today on the session as they relate to the Commission's findings. And you know, we can feel free to draw on the insights of other panelists as well, but we're going to really focus on getting some of your reflections for the next 20 minutes or so. So let's start here. How do we get research and implementation to meet in the middle? To go back to one of our earlier findings and a thread throughout the conversation today of the need to integrate research and implementation. What are some practical examples from the Commission, and any other kind of, you know, introductory reflections you'd like to share? Why don't we start with Beth?
Sure. Thank you so much. Thanks to all of the panelists. This was a fantastic session. I think my initial reflection is that the friendship bench example we've heard about over the last couple of examples or the last couple of hours is, you know, a great example of what bridging real world, you know, on the ground sort of implementation and research can look like. We heard just a few minutes ago about, you know, sort of monthly meetings to talk about evaluation and data and sort of, you know, tie the research components to implementation. And so I think this session has exemplified this a bit. To zoom out a little bit and orient to some of the things we grappled with in the Commission, we do have, I think, a very problematic bifurcation between research on implementation, right? Implementation science and implementation. Not always, of course. We hold up a couple of examples, like the Ghana Health Services Research and Development Division, and in the US, our Veterans Affairs system has the Quality Enhancement Research Initiative, where these are examples institutionally of research and implementation really being embedded with one another in kind of like a constant feedback loop. And so I think we talked a bit this morning, my time, it's not morning for all of you, but morning for me, about some of the structural factors that shape our ability to do this work. And it sounds simple, but I think is actually in practice one of the hardest things to do, because these fields have in some ways just grown up very separately in many of our societies. But having the research and the implementation in the same organization makes a really big difference. That's not all it takes. The researchers and the implementers could still not talk to each other, even if they're still in the same building. But having an organizational umbrella that ties folks together. So, building research arms or formal research partnerships between service delivering organizations, either in the community or in health systems, with researchers is one key strategy. I'll stop there and let Matt add.
Thank you.
Yeah, I think that was great, Beth. And I think that one thing I would think to add that kind of ties it back to what we were talking about today is the importance of storytelling and the importance of having like change advocates and champions in this work. So I think in order to really achieve integration between the implementation and the research, you need people on the research side who are going to champion the importance of the implementation, and you're going to need people on the implementation side to champion the research part. And I think storytelling is a big part of that, and talking about convincing those who are trained in one way the value of work in another way, not just because of its value in and of itself, but because it can also be valuable in achieving the goals that your organization or your arm of the organization is trying to achieve is important. So I think when it comes to any multidisciplinary work or any type of bridging, I think you just really can't underestimate the power and importance of people in this process, and building those relationships and being able to tell this story and demonstrate value. And value doesn't have to be demonstrated in numbers. Value can be demonstrated in stories as well.
Wow, that was that really resonated, and I think that is key, and it takes people to wear those different hats to be able to be those champions and figure out your audience and how you might need to adjust who you're sharing what information with at any given time, or how you're framing things. It's in the delivery, sometimes in the framing. So that's really interesting. I would love to build on that and just hear from you both. How do we build a field that values different types of evidence, not just RCTs? I feel like we're getting there from my viewpoint at GCC, because of the way the work that we work and the type of innovation and implementation science that we fund. But over the years, we've had to kind of bring our investment committee along with us on this journey about like the level of evidence that is reasonable to expect from the mental health innovations that we are investing in when we're making recommendations for placing our funds and whatnot. But I'd love to hear from you both from your viewpoint as well. Like how do we build a field that values different types of evidence, and where relationships and narrative and stories, I guess, are seen as part of the evidence ecosystem?
I could start with this one and then turn it to Beth. I think that this one was a key part of the commission report. For those who are interested in reading it, I think it's chapter 4 in the commission report, is talking about bringing different types of evidence to bear here. And the story behind this is, Beth and I are not trained as RCT scientists, right? That's not where we got our start, is doing interventions in RCTs. We got our start doing non-experimental research and trying to glean causal inference and causality from observational data. So what that means is trying to look for natural experiments in the world or policy changes where you can identify potentially a treatment group or a control group that kind of happened in the wild due to some policy change or something in the world. I think that also falls on the spectrum here. And I think what we argue in the report is that there's a wide spectrum of evidence and it's all valuable. I think, when we're thinking about a lot of the work we do is focused on the spectrum of causality and causal inference, where RCTs are held up as the gold standard. But in a lot of cases, RCTs are not feasible or ethical in a lot of cases. So it just really wouldn't make sense to do an RCT, yet we can still get a lot of good, internally valid, plausibly causal evidence from these non-experimental methods. I think furthermore, epidemiological evidence, which is more correlational, is key in a lot of sources, so we can do, more wide surveillance of diseases and where there might not be such experiments or natural experiments. And then lastly, storytelling as well as qualitative data collection. I think bringing mixed methods research into this and doing research with interviews and research with people's stories to take those stories and use them and not use them, but combine them and elevate them in a way that can be rigorous research as well. It doesn't have to be an either or, storytelling or research, or anecdotal evidence versus research evidence. Those things can be combined as well.
Absolutely. And we heard a powerful example from Tandy at Friendship Edge earlier about how they're doing some of that and collecting some of that data about how, participating and benefiting from the Friendship Bench intervention has changed their lives, not in terms of PHQ-9 score, but in terms of what their life looks like now. And the example of being able to grow vegetables and having that income. So that's great. Thank you so much for that very helpful response. Beth, did you want to add anything to that?
Not much. I agree with everything that Matt said. Maybe the one thing that I will add on, which very much builds on Matt's last point about it not being sort of either storytelling or RCTs, like these things should go together, is that I think of research and have always thought of research as producing evidence, to solve problems, and different kinds of evidence give us sort of different angles on how to solve the problem. And linking that back to this idea of like a story, like no one study or one method is going to produce like the whole story about how to solve a problem or even why the problem is happening in the first place, right? And so, RCTs answer a very specific research question, a very specific type of research question. Does this kind of intervention have an effect on X outcome? And it's usually like one primary outcome that the study is powered to address. And that's great. That's valuable evidence. I'm not proposing that we replace RCTs or get rid of them entirely. But when you present that evidence to decision makers or communities that would be potentially participating in the program of interest, they have a lot of other questions that they want answered too about how you implement this, and what about these other outcomes, and like what about how is this going to work in this different type of community that isn't where you tested it. And you need other kinds of research methods to answer those questions and kind of tell the whole story. And so when I think about making a compelling case for why we need methods that are beyond or in addition to RCTs, that's how I think about it.
Yeah, that's great. That really resonates in the sort of project level work that we do and invest in here at GCC. There's a question in the chat from Vijay. Would love to hear what are the opportunities and barriers to research methodologies that embed lived experience and community engagement in mental health research. What is the current uptake of these methodologies? I'll invite Matt and Beth to start. Either one of you, whoever feels compelled to start here on this one.
You can start this one.
Yeah, I can start this off. I think that the answer to that question can depend a little bit on sort of specific environmental constraints. Like, is the research being conducted in an academic institution? Is it being conducted by a government agency? And sort of in what national or international contexts are those happening? And anyway, so there's some specific nuances here, but I think that some of the big challenges that we face are operational. So let's put aside some of the other challenges that I'll touch on in a moment that might never get us to the point where researchers really want to sort of partner and embed people with lived experience. Let's say we're in a world where a research agency or research team is really enthusiastic about ensuring that people with lived experience are engaged. There can be, as I said, just a bunch of operational challenges with that. Are there mechanisms to pay folks for their time if they're not already employed by that organization? Does the organization that's conducting or funding the research have... Oops, somebody is...
Dr. Debora, I think you might not be on mute.
Yeah. Does the organization have, does their human resources sort of have job descriptions that allows hiring of people with lived experience to participate as a full-fledged member of the research team, which in many cases is ideal? Does the organization, in fact, have policies that might preclude hiring someone with lived experience? That's more common in addiction than mental health, but can be a challenge in mental health as well. So, will institutional review boards, support adding people with lived experience, perhaps in a, community partner board capacity to the study team so that they can actually work with the data in a way that is effective? Sometimes the answer in my experience is no, or that is very hard to do. So there are, I think, like institutional and operational barriers in the research field to doing this well. And I think we're making some progress slowly on overcoming some of those, but they still exist.
Absolutely.
Yeah, go ahead. I'll stop there.
Okay, thanks, Beth. There's a couple more questions here I'd love to get to because they're really interesting ones, and I'm going to just pose the next one to you now. How should we be thinking more proactively about storytelling as a tool in mental health implementation and advocacy? You touched on this a little bit, Matthew, in terms of the importance of being a bridge and kind of people leading this work and championing this work. But is there anything else you'd like to add around the power of storytelling as a tool, or how to use it in mental health implementation and advocacy work, either with decision makers? Yeah.
I think the thing I'd add to what I was talking about before is the importance when communicating the evidence, right? So I think like one strategy that I try to use when communicating with decision makers is really to combine the stories with the numbers. So talk about one person's path and explain or if you're doing a policy evaluation, one state's path, one country's path, and then really pair that with the one key outcome number. So you can say, hey, here's an example of, and here's a story of how it works in one setting. We did research to see how this worked overall, and this is the one number we found. So I think pairing those numbers, and I think when we think about it, the stories are the things that really open the door, because the human connection, and we're all human, is what opens the door. But numbers are what keeps it open long enough to get funding, to get sustainable funding, right? And I think the showing the numbers can demonstrate the longer term value.
Fantastic. Thank you so much. Okay, I'm going to move to our last question here. Maybe just briefly, could one of you comment on this? This is a big question, but what would it take to make workforce integration, indicator alignment, and policy windows part of how we plan for sustainability from the start? I know we definitely try and apply these lenses in our investment decision making at Grand Challenges Canada. Even in the early stage of an innovation's journey, we don't expect them to have the whole scaling pathway mapped out and validated by any means, but we do expect that innovators are aligning themselves with policy frameworks and government plans and whatnot. But if there's anything you'd like to add here about what it would take to align these things from the beginning of research and implementation work, that would be super interesting to hear from you.
Yeah, I mean, I think the example you just gave of funders having an eye on these things and both sort of requiring and supporting grantees in doing them is certainly one helpful lens. I think in some ways the policy windows piece is the hardest here, in that policy windows can be unpredictable in terms of when they're going to open. And there, I think it's really helpful and important to sort of early on have an analysis of the policy landscape. You probably can't say, I know for sure this policy window is going to open in 6 years, but you can figure out who the relevant players are and get a sense of the landscape, and this idea that, oh, there could be a window that opens if sort of ABC thing happens. We don't do that often enough. That's something that often neither scientists nor implementers are trained to do. Political scientists, perhaps. So maybe it's an argument for aligning political scientists with our teams.
Yeah. For sure. Yeah, I know any innovators we support, sometimes they know a curriculum review might be coming up in 6 months' time and they can kind of plan towards that, but oftentimes they don't necessarily have that level of visibility into the policy process. Okay, I have one question I'd love to pose to all of our panelists from today. I'm going to ask Dr. Debora, Dr. Patience, Dr. Tandy, if you're still with us, Dr. Allison Schaefer, Dr. Matt, Dr. Beth, please keep all of your cameras on for this final question today. Very briefly, before we turn it over to Deb for closing remarks, what is one piece of advice you would give to others seeking to create impact for mental health interventions in their context? What should they be thinking about? And Dr. Patience, why don't we start with you? From your experience. And you're on mute, sorry.
All right. So what I would say is, when you start your research, think about the end goal. So if your end goal is to then make sure that that research becomes implemented by the country, or it's not just a project, it becomes something that is going to be adopted at national level. If you think about it on the onset, you then start doing the keeping the individuals you are going to work with in the loop. Yeah, so having the end goal in sight makes a lot of difference if you are going to then implement the research that you are doing.
Excellent. Thank you so much. Okay, Dr. Debora, anything you'd like to add? One piece of advice you would give others.
Yes, thank you. I would say at the onset, it would be important to think about research so that you marry it with your implementation. In retrospect, there are things that we are seeing, oh, we should have documented this, or we should have documented that to make amazing pieces of evidence. So starting with your M&E and embed research in it. Thank you.
Thank you. Have an M&E plan from the start and embed research. Dr. Allison, let's go with you.
I was going to have two, but Deborah's just said one of them. The other thing I would say is make sure there is budget and funding for the key people, the people to see it through for timeliness, the people to see it through over years, over continuity, and in order to build those important relationships. I still maintain in all our work, people matter, and they matter for more reasons than just, doing the work. They matter for the value that all of this stuff adds.
Excellent. I don't see Dr. Tandy, there you are. What's your advice?
I think just to reiterate what everyone is saying, from the get-go, think about sustainability, right? How is your model, your intervention, how can you make it sustainable? Rather than when you've implemented, you're now thinking, right, so how can I make this sustainable? And it's not easy, it's messy, but it can be done. And the last thing is, I liked what Matthew said. I think I'm going to write it down. Storytelling opens doors, but data also keeps that door opened. I think that was a very interesting way of putting it. So yes, thank you.
Fantastic. Dr. Matthew, would you like to add anything?
I think this has been my closer for all three in this series, which is remember the power of non-experimental evidence.
Excellent. Love these sound bites. Thank you. And Dr. Beth?
Yeah, I think my recommendation would be to develop interventions with the people who will participate in them and benefit from them.
Absolutely. Snaps for that. Excellent. Okay, well, thank you all. This was a fantastic conversation. I found this very, very enriching and meaningful and practical as well. So many great examples of how you're all working together to tackle some of the barriers coming up to integrating Friendship Bench into the primary healthcare system in Zimbabwe, and some really great tangible examples shared of the special initiatives progress so far from Allison. And I think my colleague Deb is going to do a bit of a recap for us. So I'm not going to recap it all. I'm going to turn it over to Deb and just thank everyone so much for your time and graciousness today and candor. And thank you. It was really great. Deb, over to you.
Thanks so much, Britt, and thanks so much, everyone. Yeah, I think we heard some really incredible examples and sound bites throughout the entire symposium. And I think if I can just recap it a bit and bring forth some of the key messages I heard, we heard from Allison at the beginning that real-world implementation can be really complex and very messy. And we heard from Dr. Thandiwe about how the Friendship Bench is doing a fantastic job at merging both qualitative methods and personal stories with the RCTs and the hard data, followed with, hearing from Dr. Providence and Dr. Debora on the importance of having champions at the government level and also building a strong evidence base so we can champion sustained implementation, and, their experiences in championing and supporting the Friendship Bench for many years. And I think, the panel with Matt and Bet was a very good closing to all of this, hearing about how mixed methods and how research methods can be context specific. So RCTs may not work in all contexts. And then hearing from Beth about how not one study can tell the full story of the problems we're trying to solve. And I think all of this just really speaks to the importance of continuing to share our collective stories and lessons in implementation and in research of what worked and what didn't, and also continuing to champion each other and lived experience in both research and implementation, because at the end of the day, as Allison said, people matter, and using their stories as evidence and embracing them together along with more quantitative data is the way to keep learning from each other. So that brings our session to a close. before we wrap it up, I would like to mention that the Alliance team has shared an evaluation form in the chat, so please do fill that out. I would like to thank all of the speakers. Thank you so much for sharing your experiences and approaches with us today. And a big, big thank you to all of you in the audience for joining us and sharing your thoughts and questions in the chat with us. Thank you also to my colleague Britt for running the session so smoothly with me, and to the Alliance team and the Lancet Psychiatry Commission for organizing. A final reminder that this session was recorded, and the Alliance team will share it with you in the coming days, so you will be able to watch it again. And overall, thank you so much, everyone, for making this last session of the symposium series such a great success. Take care, everyone. Bye for now.